Giuseppe Rosano. I'm Professor of Cardiology at St. George's University in London, and I'm a member of the Cardiovascular Working Party at European Medicines Agency. So this, the first talk is what is the need in terms of evidence from regulatory agencies in order to approve drugs. And since November 2005, we have a new regulation in Europe, which is the possibility of approving drugs with different pathways. So one pathway is the centralized procedure, where the drug is applied to the European Medicines Agency and get one approval that is a marketing authorization within all Europe. The other one is a decentralized procedure where the drugs applies in 3 different countries, and then it goes through a procedure, a expedited procedure at the European Medicines Agency for its approval. And the mutual recognition is more something that had been in place for all drugs before 2005. So drugs that were in the market in 3, 4, 5 countries, but not in all countries, and therefore to harmonize the type of approval that was for all European countries. So the centralized procedure is basically says that there are some type of indications that are compulsory for that type of application. So any new drug that is approved in Europe that is either for biotechs or recombinant DNA, gene-expressed therapies, CAR-T, or monoclonal antibodies, or drugs for specific therapeutic areas like HIV, diabetes, neurodegenerative disease, and autoimmune disease, or for orphan drugs, they should go through a centralized approval in Europe. So they have to submit their dossier to the European Medicines Agency. Now, of course, there are other type of drugs that should also be approved through this pathway, so those with significant innovation. And now the term innovative was something that probably a concept has evolved over the years, because initially we thought that something that was biological was more innovative. More recently, we've understood that even small molecules can be very innovative, and therefore the concept of innovation is changing, and innovative is anything that will bring a significant clinical benefits. So we have the other possibilities that there are the mutual recognition procedures for products that have already an existing marketing authorization, and the decentralized procedure that is only possible if there's not a previous authorization for that drug, and that is an expedited type of consultation at the European Medicines Agency. Now, of course, there are some rules for drugs and notices of guidance at the European Medicines Agency that basically set the standards for requirements for trials that have to be conducted in order to have a drug approved. And then we have different requirements for example, ischemic heart disease, heart failure, and lipid disease or diabetes. Now, for ischemic heart disease, as you may well understand, we have different scenarios, and we cannot apply the same requirements for acute coronary syndromes or for chronic stable angina. So for acute coronary syndromes, we are more interested in efficacy in terms of mortality. For chronic stable angina, we have to say that up until now, we don't have one single drug that has ever been approved as an anti-anginal that improves survival. All of them are approved on the effect on myocardial ischemia. And then we have drugs that they are all still under the umbrella of chronic stable angina, but they are more for secondary prevention and they are more for risk factors. Now, when we talk about acute coronary syndromes, when we assess a drug, we are interested in mortality, and it is important to balance mortality and cardiovascular mortality. Sometimes it's more important to have a cardiovascular mortality, and of course that has a different importance in terms of timing according to the time when you give that intervention. So say you give thrombolytics for acute myocardial infarction, you're interested to see whether there's an efficacy in terms of in-hospital mortality, then 30 days and 60 days mortality and 90 days mortality. That is more to see that it's safe. Then, of course, if you look at 1 year, that is an interesting effect, but probably is less important and relevant than the effect on mortality at 90 days, because it's something that is given as one shot. Of course, we need to see whether there's an effect on mortality, because sometimes you may have a reduction in cardiovascular mortality, but an increase in mortality. All of you are too young to remember the initial studies with RTPA. RTPA was proven by the GC2 study to be effective in reducing mortality in patients with acute myocardial infarction, and they were given heparin. Then the Americans conducted the GUSTO-1 trial, where they gave very high dose of heparin in association with RTPA, and the study showed an increased mortality, but increased events mostly because of cerebral hemorrhage. So you see, therefore, sometimes you have a primary endpoint that gives you the efficacy, and then a secondary endpoint that is more a sort of safety endpoint, that basically if you see an effect on your primary, but then the secondary has, say, a disturbing effect, then you may question the efficacy of that drug. Of course, there are other endpoints that are of importance in the assessment of these drugs, like major cardiovascular events, reinfarction, sudden death, and bleeding. And again, for bleeding, we may want to discuss, and we can discuss for hours, on the different ways of assessing bleeding risk. One problem is what we choose as a comparator. Now, today, there are few centers, but still many centers use RTPA or thrombolysis. But the gold standard intervention is angioplasty. So at the end, we are testing more and more antiplatelets regimens, anticoagulants, and antiplatelets. And the Augustus trial has been just recently released at the ACC a few days ago, that basically showed that anticoagulants plus and an antiplatelet is more effective than the use with aspirin. So the choice of comparator is important, whether you use another antiplatelet, you use double antiplatelet, you use an antiplatelet plus an anticoagulant. But what is important is that the comparator you use is then will set the standard for your for your type of indication in that specific population. Then, of course, composite endpoints can be used. And sometimes, if you compare two treatment strategies, the bleeding risk is also important. I mean, this is maybe not as relevant for acute coronary syndromes, but if you think at the efficacy of the new oral anticoagulants in patients with non-valvular atrial fibrillation compared to warfarin, they've been approved mostly because they were safer in terms of bleeding risk. Then we have, in terms of acute or chronic stable angina, we have the treatment of the risk factors. In risk factors, for example, we have the lipid-lowering drugs. You can have a lipid-lowering drug that is approved just for the reduction of lipids. And then you have drugs that are approved for reduction of mortality and morbidity. Until a few years ago, for example, we had the evidence from the WASCOPS trial, from the FOREST trial, from TNT, that simvastatin, pravastatin, atorvastatin were reducing events. But when rosuvastatin came on the market, there were no data to support the benefit. And so for some time, we had drugs that were approved for reduction of lipids and reduction of mortality, and drugs that were approved only for reduction of lipids. Then, of course, the Jupiter came, and there was the approval for reduction of events also for rosuvastatin. But yet we still have drugs that are used for reduction of some lipid subfractions, say omega-3s in hypertriglyceridemia, fenofibrate in hypertriglyceridemia, where the main aim is to reduce the lipid profile. And of course, when you approve these drugs, you approve them on the basis of their efficacy on 12 weeks. And then you look at the long term, so at least 52 weeks, but mostly to assess the safety. Because one important point is that whenever we approve any new drug, the efficacy is always a balance between the benefits and the risks. And in the approval, since drugs go in the general public, risks are very important. So, and usually the detection of risk is underestimated in clinical trials compared to what we see in real life. Then, of course, we have the same thing for blood pressure, and we'll come back on blood pressure later. But when you approve a drug for blood pressure, you can have a drug approved because of the reduction of blood pressure. And for that, you need just a 12-week versus placebo versus comparator, and then a 52-week for safety. Basically is the same thing. Of course, there are other drugs that have been approved and have shown reduction of events within the antihypertensives, but not many. It's more the strategy that has been shown to be effective rather than the single therapy. We'll get back to that later. Now, regarding chronic stable angina, then we have the anti-ischemic effect. And regarding the anti-ischemic effect, we have no evidence whatsoever that they reduce mortality. There's not a single drug going from beta blockers to calcium channel blockers to any other anti-anginals that have ever been shown effective in reducing mortality in chronic stable angina. Beta blockers have shown to improve survival, but only and solely in post-MI patients with left ventricular dysfunction. Apart from this small group, there's no evidence that in patients with residual ischemia, they improve survival. So when we assess any new drug, of course, an anti-anginal drug, we need to have a drug going through the phase 1, phase 2, and phase 3. And of course, in phase 2, we need to understand the effect of the drug on pharmacodynamics, the effect of the drug on blood pressure, heart rate, central pressure, and whether it induces significant bradycardia, if it's a drug affecting the rhythm, and if it affects the cardiac cycle, the effect on the ECG or on specific electrophysiological parameter. Then, of course, you need to have a sound rationale for its use. So if it's a drug that induces vasodilation, then you need to prove that the drug has an effect on coronary flow. If it's a drug that reduces heart rate, you have to show that it's reduced heart rate safely. And then you need to conduct a study to show its efficacy. Now, regarding the study on efficacy, you have, first of all, to look at the effect after withdrawal of the anti-anginals. So it is perfectly safe to do studies after withdrawal of all anti-anginals. Of course, you can allow the short-acting nitrates during the period of washout, but what is important is that you won't allow any sublingual nitrate in the 3 hours before the test, because the effect of any sublingual nitrates vanishes after 3 hours. And you need to do studies initially to show the efficacy of the new drug compared to placebo. Then you can decide how to assess myocardial ischemia. And we know that we have different ways of assessing it. We have the exercise ECG that is the gold standard. Alter monitoring is less and less used. Then scintigraphy, myocardial perfusion scintigraphy, may be a good way, but it's a semi-quantitative type of assessment, and therefore shouldn't be preferred, and because you cannot give a clear number and a clear assessment. And similarly, stress echo. Stress echo is very good for diagnosis, but it's not good to assess the efficacy of a drug because of the possible variability between different centers. Of course, you can use a centralized lab, and that then looks at your echoes. But, for example, that is a pain, because core labs are always a pain. We conducted a study, and I think we are one of the largest heart failure center in the UK. And I think we have excellent quality, and we recruited several patients, and I would have to say that 80% of them were turned down because the core lab said that the echo was inadequate. And then it's, of course, you understand why the using imaging is difficult for approvals, because then you will require your larger number of patients plus all the dropouts that come because the core lab wants to have the very nice patient that is the young male thin with a good acoustic window where you can get a very good view without any interference, and this is just not feasible. So when we assess with the exercise test, we look at the exercise time during the exercise tolerance test as the main test. And that being the reason why, because you can stop the exercise test because of ECG criteria, so more than 3 millimeters of ST segment depression. You can stop it because of crescendo angina. You can stop because of symptoms. So the exercise tolerance of the symptom-limited exercise test is the best type of endpoint that tells you the efficacy as an anti-ischemic. Of course, then you have the time to 1 millimeter ST segment depression that gives you the time to ischemic threshold. That is an added type of endpoint. But all the others have less importance in terms of ischemia. Of course, since a drug will receive an approval as an anti-anginal, then you need to show an effect on the number of episodes of angina, and the number of GTN tablets that are used is a good surrogate endpoint to show the efficacy. When you design this study, you do the study against placebo, and you need to show efficacy against placebo. Then you have to compare with an active comparator, and it's usually compared with the beta blockers. This is not why beta blockers are recognized to be very effective, but just because for historical reasons they were the first to be approved, and then everybody else compared to beta blockers. And then you can use it if you want as a second line, your new drug plus beta blockers versus beta blockers plus placebo. I will show you very briefly just one example of what I said, because otherwise everything remains theoretically and it's a waste of time. So this is the last of the drugs approved as an anti-anginal, is ivabradine. So ivabradine is an IF blocker, so it blocks the current IF in the sinus node and reduces specifically and selectively heart rate. And when they developed the drug, they used this parallel type of design where they compared to placebo the 2.5, 5, and 10 milligrams. And patients underwent an exercise test at baseline and another one before randomization. This is important when you perform exercise tests, because if you say that you want less than 20% variability between these two tests, then you reduce the variability of your patients, and therefore you increase the possibility that what you're seeing is a real true effect. Then they did another exercise test here, and then they gave ivabradine at maximum dose in open label, and then exercise test again. And what they found was that there was a sort of linear relationship, a good linear relationship between dose and efficacy. They've chosen at the end the two intermediate doses, because the 10 milligram dose was had some side effects, and for that reason was discontinued. So remember this. From the phase 2 trial, they decided not to market the 10 milligrams dose because the benefit risk of the drug was not favorable. And you will see that that is as an importance later. So then they did a study in order to confirm the efficacy against atenolol. So basically, they randomized patients in three groups. One group received atenolol, another group ivabradine, and the other group the 7.5 milligrams of ivabradine. And basically, they showed that there was a greater effect of ivabradine compared to a beta blocker in terms of exercise capacity. But then, and that drug was approved and was approved for use as alone or in association with beta blockers. But then, probably they wanted too much, and they conducted a very silly study. That was a study to compare to see whether ivabradine was different from the beta blockers in reducing events. The only problem is that 88% of patients in the ivabradine group were also receiving beta blockers. So basically, this was a study of beta blockers plus ivabradine versus beta blockers. So it didn't make much of a sense in terms of efficacy. And what else they did is that, you remember, they discarded the 10 milligrams initially, and they tested 7.5 and 10 milligrams of ivabradine. At the end, so a drug that was initially not approved and was not approved at that time, there was no effect on survival, but in patients with refractory angina, there was a significant increase in events in the ivabradine group, and that was related mostly to an interaction with calcium channel blockers because of the very high dose. So you can see that in this subgroup there was this increase in event, and that was especially seen in younger patients where there was the up titration of the drug to the 10 milligrams. So the agency reviewed the case, reviewed all the different specificity, and especially the use of the 10 milligrams that was not approved, and therefore maintained that the benefit was still there for the 5 and 7.5 milligrams. Now, so that was an example on when you develop your drug, what you need to get, and what you shouldn't be overdoing. Because if you want too much, then maybe you get into troubles. And so if you want to design your study, you have to design with the doses that have been approved and for which you have clear evidence of efficacy, but also of safety. Now, regarding heart failure, of course, we have different populations, again, acute and chronic. And for acute heart failure, it is important to understand that we tend to treat patients. All the drugs that are used within the first 48 to 72 hours when patients is admitted, and not later. For chronic, we take patients who are stable, who've been stable for at least 3 months. So you see that basically either we treat patients immediately in terms of drug approval, or we treat patients after 3 months. So there is this gray area between the 3 months and immediately after the infusion that was not covered. Now, the new note of guidance released by the agency includes these patients, those patients that after infusion, as patients with chronic stable angina. In order to assess efficacy, I will tell you later why we need to look at mortality in heart failure. And I'll have a presentation on heart failure specifically, and I will show you why we got to the fact that in order to have drugs approved for heart failure, we need to have mortality. So for acute, we need the hospital and 4 weeks mortality, and long-term mortality and duration of hospitalizations are important. But we have to say that probably studies have been very ill-designed recently, because in the past 10 years we haven't had a single drug approved for acute heart failure. For chronic heart failure, we look at mortality, morbidity, or composite endpoint. Of course, we can use composite endpoints in order to increase the event rate and therefore reduce the sample size. Otherwise, we end up with 20,000 patient studies. And so we can use the hospitalizations for heart failure, but in that case, it is very important to be sure that to know the causes of hospitalizations, because often up to 70% of the hospitalizations are not cardiac. So we need to have a central adjudication in order to be sure that that is really a cardiovascular hospitalization. Or now we are also accepting the worsening heart failure without hospitalizations, because in many centers now patients are managed in outside the hospital, say in the GPs, in primary practice, where for example, they receive an IV diuretic and then they're sent home. And in that case, that counts as an hospitalization for heart failure. The new way towards where we are going, and in order to reduce the number of episodes, is the use of what we call recurrent morbid events. Now, you know that if you do a mortality morbidity study, you randomize patients, and then once the endpoint is reached, say patient gets hospitalized, then it gets censored and is not followed anymore for that study. But we have 30 to 40% of patients that get one hospitalization today, they go home, they come back after 3 months, they came back after 4 months. So it's if you count all these events as a recurrent events, then you understand you reduce the number of patients required for trials. So these are now acceptable endpoints. Then we have a list of secondary endpoints that basically we use just to give the justification and the biological plausibility, but are not used for approval. And what is important is also what is a meaningful change. Because the difference of approach that we have in Europe compared to the US is that in US, most of the decision is led by the biostatisticians. The P is below 0.05 or 0.025, the drug is approved. In Europe, what is important is that the change that you see is meaningful. So, and what is a meaningful change? Is any change that is correlated with an improvement in mortality or morbidity. And I will show you some examples, and you can clearly see why this is important. Now, this is the study with serelaxin, and serelaxin at the end was not approved for patients with heart failure. And you can see that if data are presented in this way, then you may say, oh, well, there is an effect of serelaxin in reducing the area under the curve of dyspnea. You see that the amount of dyspnea was significantly improved by serelaxin. Then you look, what was that change? The change was 0.4 millimeters in a visual analog scale. So basically you're given a paper like that with a 10 centimeter scale, and then you have to thick. And if this is the scale, this is the change. So 4 millimeters. So that was not considered to be meaningful. And for that reason, amongst others, the drug had not been approved. Then you may think exercise capacity is effective and is important. In this case, we know in pulmonary hypertension, riociguat was approved because of improved the exercise capacity, but mostly because it reduced the worsening of, exercise capacity. But then after riociguat, it came macitentan. Now, you may say, there was on the 6-minute walking test, there was macitentan improved exercise capacity by 7.4 meters. Much? Nothing? Probably very little. The placebo group worsened 10 meters. So is there an effect? Possibly. Then after that, it's the drug has been approved conditionally. So it means that it's approved for 2 years, and then it's given the as requested to have other data. And you can see that then the event that was associated, this effect on exercise capacity was associated with a significant reduction in events. So in that case, a small change in an endpoint that was probably making a sort of sense then was associated with long-term effect. And the same in pulmonary fibrosis. We had pirfenidone, where you see that there was a change in FVC that declined with the pirfenidone or placebo, but declined much less with pirfenidone with placebo compared to placebo. And that time was thought that was amenable for an approval. It was approved conditionally, and after 2 years, the pirfenidone was shown to reduce the progression-free survival in patients with pulmonary fibrosis. So, how can we define a meaningful change? A meaningful change is a change that correlates with mortality and morbidity. What is important is that it has to be related to baseline function. It can be an attenuation of the decline in function and must be significantly related to the disease. So there must be what we call biological plausibility for that.